Our first substance that we'll cover is going to be alcohol. Alcohol is going to be important because it will show up on most board exams. You'll have to know acute intoxication, some chronic complications, also withdrawal symptoms and how to treat it. So alcohol is going to be pretty important. When describing an alcoholic, what comes to mind? Well, thinking in the test writer's mind, most demographics for alcoholics are going to include males between the age of 20 and 40, so young adults. I'm not saying that all alcoholics are male between the age of 20 and 40. I'm just saying most of the time. You may also see an 80-year-old grandma who's an alcoholic. But on test day, if you have a male who's between the age of 20 and 40, alcoholism must play into the bigger picture, at least be on your differential. So it may also give you the softball question of letting you know that there's alcoholism in the family history. So you've got this patient who's a prime candidate for alcoholism. What are you going to do? Well, you're going to screen them for alcoholism. And to screen them, you're going to use your CAGE memory aid. CAGE. Hopefully you've seen this. It has shown up on the board in the past, so make sure you know what the screening tool is. The C in CAGE stands for cut down. Have you ever felt like you need to cut down on the amount of alcohol you're drinking? A stands for annoyed. Do people around you seem annoyed by your drinking? Do you get annoyed by the criticism of others about your drinking? G stands for guilty. Do you ever feel guilty about drinking? And E stands for eye-opener. Do you need a beer or an alcoholic drink in the morning to get going? So those are your screening questions. This screening tool has a very high sensitivity, so it picks up most people with alcoholism. And a positive CAGE screening questionnaire would be positive or answering yes to any of these four questions, so they feel like they're guilty about their drinking. So one or more positives or yeses to these questions is a positive screening, and you need to dive a little deeper into their alcoholism. So to talk about alcohol, we should first start off with a case presentation, a case example. I think that'll get the juices going. So let's first start with this one. You're a psych resident requested to consult on a surgical patient. That patient is a 40-year-old man, and he's on post-op day 2 for a cholecystectomy. The nurses report that the patient has become agitated, profusely diaphoretic, and reports transient hallucinations. His vitals are as followed. He has a 99.7 temp. He's tachycardic at 118. His tachypnic at 22, and he's hypertensive. What's the next best step in the management of this patient? Is it A, admit the patient to the psych ward, B, give methadone, C, administer disulfiram, D, give diazepam, or E, order a stat chest x-ray? Well, let's go to this. I kind of pulled out or teased out some of the more important things to look at. Remember, I said always check out the demographics of the patient in question. So in this example, we have a 40-year-old man. Remember I said you need to throw alcohol on your differential in this demographic. So we've got a 40-year-old man. He's been in the hospital for a couple days now following surgery. The nurses report that he has some symptoms. He's agitated. He's profusely sweaty or diaphoretic. And he reports hallucinations that come and go. Those hallucinations are not permanent, but more they come and they go, so they're transient. His vital signs are a little bit elevated. Notice that he has that elevated pulse rate, maybe a little bit of a fever, maybe a little bit of hypertension going on. So all these should kind of cue you into what we're looking at. So I would say that this patient is in alcohol withdrawal. What are you going to do to best treat this patient? What's their next best step? Yeah, hopefully you're thinking, give diazepam, a benzodiazepine. So, why diazepam? Well, it's more of a longer acting benzodiazepine, and what we're going to do is we're going to start at higher doses and eventually taper off following symptomatic resolution. So, we'll cover this more in detail, but for this, realize that we have a 40-year-old man. He's been in the hospital for a couple days now. In the hospital, they don't serve alcohol unless if you sneak it in. So this man has probably not had anything to drink for a couple days. Typically, alcohol withdrawal will always have this in the question stem. So if you ever see this on a question stem, I want you to immediately think, is it alcohol withdrawal? So that's one little cue that you can use. Most test writers will have this sentence. A blankety blank man, a young adult man, comes in on the second or third day after a surgery. He develops symptoms, and the symptoms are related to these. So we'll talk about all this in a little bit. I just wanted to give you a clue onto why we're covering alcohol. So, back to our discussion. An intoxication of alcohol, everybody's seen it before. Even if you don't drink, you at least know kind of what alcohol intoxication consists of. You're going to see the disinhibition. What is disinhibition? Well, it's doing things that you typically wouldn't do when you're sober. So if there's a really pretty girl in the corner, but when you're sober, you're really shy. Well, after you're intoxicated with alcohol, some of your inhibitions go down, your bar is set a little lower, maybe you're more social, so you'd possibly approach that attractive significant other. So, that's one example of disinhibition. Emotional instability. So everybody's heard of the happy drunk, the sad drunk. It's because your emotions fluctuate or they're not stable while you're acutely intoxicated with alcohol. You may also see ataxia. So everybody's seen that drunk person who's acutely intoxicated. They're stumbling around. They're not able to walk that straight line. They're unable to keep their balance. That would be an example of ataxia. They also have memory issues. So memory impairment. They're not able to remember things as well. They may black out, for example. So I recommend not drinking the day before a test if you're hoping to study that night, because you're not going to remember things as well. And then lastly, kind of the more intuitive one, you have poor judgment. Everybody's heard stories about making very poor decisions while you're under the influence of alcohol. So an intoxication refers to an acute overdose of alcohol leading to symptomatic impairment. So this patient, for example, may exhibit disinhibition, ataxia, all these. This isn't a complete list. However, these are some of the more important ones that you do need to remember for board. So if you see a descriptor about a patient who's stumbling around, kind of like I'm stumbling for words right now. However, this patient's stumbling around the room because they're not able to keep their balance. You need to think, are they acutely intoxicated on alcohol? We can also take a look at some physical findings that you would find on the physical exam. So, for example, if you have a patient who's been drinking 10 or more beers a month for the last 10 years, what are some long-term physical findings that we could see on physical exam? That would include palmar erythema. So that's simply redness on the palms of the hands. That's one of the long-term side effects of alcoholism. You may also see telangiectasias. So telangiectasias are dilated kind of spider blood vessels near the superficial surface of the skin. And then also there could be indication for liver disease. No, you do not visually see liver disease on the physical exam. However, you may feel hepatomegaly. Now, let's backtrack a little. So if you find hepatomegaly, that could be an indication that there's fatty liver disease going on due to the alcoholism. So you may feel a palpable liver 10 centimeters below the costal margin. I mean, you would be able to recognize or palpate an enlarged liver. So that's why I listed it under physical exam. Because you don't see liver disease, you would feel liver disease. Alright, so now let's move on to some of the chronic symptoms that you would see after years of drinking large amounts of alcohol. The first one that we'll talk about is Korsakoff psychosis. Now, Korsakoff psychosis doesn't happen after 1 or 2 casual weekends of drinking a couple more beers than you're supposed to. This is more of a long-term chronic symptom. And what it is, it's not really a psychosis in terms of psychiatric terms, where psychosis, you may see that more with schizophrenia. In Korsakoff psychosis, it's more of an anterograde amnesia. So what that is, it's having trouble remembering new things from this point on. So the next 10 words I'm about to say, you would not be able to remember those. That would be an example of anterograde amnesia. An example of retrograde amnesia would be not being able to remember your son's first birthday, or not being able to remember your quinceañera, or whatever example it may be. It's not able to remember things in the past, so that would be retrograde. However, Korsakoff psychosis is anterograde amnesia. Korsakoff psychosis is usually irreversible. And why is this? Well, it's thought to be caused by decreased thiamine levels, so vitamin B levels in the long term, so decreased thiamine levels chronic. I'm not talking 1 or 2 days of decreased thiamine levels. I'm talking long-term decreased thiamine intake. And decreased thiamine levels is indicative of alcoholism, where you just don't get the required vitamins that your body needs. So anterograde amnesia is the number 1 irreversible kind of thing you need to remember for Korsakoff. Then we've also got Wernicke syndrome. Wernicke syndrome is going to be more of the reversible chronic effect, or the chronic symptom of alcoholism. And it's also thought to be due to decreased thiamine, but a much shorter or acute bout. So what you'll typically see in Wernicke syndrome is delirium. Yeah, we'll talk about delirium versus dementia later on. But you'll see delirium, an altered level of consciousness, and then you may also see some ophthalmoplegia. What in the heck is that? Well, put in layman's terms, it's paralysis or weakness of the ocular muscles, so you wouldn't be able to move your eye in a certain direction, or you would have possibly diplopia because of a weak muscle, so you kind of get double vision in the eye. And then also you may see some ataxia, all due to the decreased thiamine levels. So the delirium, the ophthalmoplegia, and the ataxia are all kind of the triad of Wernicke syndrome. So let's think back to our case example. We had a patient who had not had alcohol for a few days. They developed some symptoms. You saw that tachycardia, maybe some autonomic instability. Autonomic instability. That's the $1 million word of the day. And why is this? Well, it's because it has a constellation of symptoms. You don't diagnose somebody with autonomic instability based on one symptom alone. No, it's kind of more of a constellation of symptoms. So what are some examples? Well, you get tachycardia, so that increased heart rate. You may also see some fever, or increased temp. You don't get increased fever. You may also see that hypertension, or an increased blood pressure. So those are all some physical vital sign findings, but you may also get disoriented, agitation. Remember, your autonomic system, your parasympathetic, sympathetic system is unstable. Typically, they work in a nice harmonious action. If you go into alcohol withdrawal, it kind of throws off your nervous system. It doesn't function the way it needs to. So you get these vital sign changes. You get this agitation. You may get diaphoresis. Diaphoresis is simply sweating or excessive sweating due to autonomic instability. You may also get some GI issues, so you may see some nausea. You may get GI issues like stomach cramps, for example. Sleep issues, insomnia. Alright, So we've got quite the list here. You may feel anxious. Now, all of this is kind of building up into something. So we have autonomic instability with alcohol withdrawal. What happens if we take a patient, they drink a beer, and you measure the time from when they had their last beer to about 6 hours later? So we're talking 6 to 8 hours later. Well, you'll see some agitation, maybe some jitteriness. So they're jittery. 8 to 12 hours after their last intake of alcohol, you may see some perceptual disturbances. So perceptual disturbance could be a transient hallucination. Remember, that was a buzzword that we saw on the question stem that we practiced earlier. So transient hallucination. All right. And then what about 12 to 24 hours after they're sober? So they haven't had a drink for almost a day now. They can develop seizures. And then 24 to 48 hours, even to 72 hours. So 1 to 3 days. Remember, our guy was 2 days post-op, so he hadn't had anything to drink for probably 2 to 3 days at least, unless if somebody snuck him something in. So let's throw 3 days out there. So what they can develop is a thing called delirium tremens. So I'm going to star autonomic instability, and I'm going to star delirium tremens. This is a potentially fatal side effect of alcohol withdrawal. Not everybody who gets delirium tremens is going to die, but there's statistics out there that show anywhere from 5 to 10% of patients who develop this delirium tremens can have such great autonomic instability that they can die. So, what is delirium tremens? Well, let's look at the word delirium. Well, that kind of sounds like disoriented, agitation, kind of part of our autonomic instability picture. And then we've also got tremens, so tremor, seizures. So they can develop a tremor that's benign and kind of results as a handshaking, or they can develop a full body seizure. So what this is it's more of a constellation of our autonomic instability, but to a greater extent, so that they develop a tremor, a seizure. It is more life-threatening. So that's one thing that you have to monitor when going through alcohol withdrawal. Typically, alcoholics need to be admitted to a inpatient setting so they can be monitored and make sure their vital signs and their autonomic system is working properly. Now, that brings us to our next point. How are you going to treat a patient? Well, let's start off mild. They haven't drank too much. We kind of nipped it in the bud. They've been drinking pretty heavily for the last 8 months. They're not chronic use, but for the last 8 months they've drank a lot more. You used your cage questions. You determined that they have alcoholism. What you can do is you can recommend group therapy, such as Alcoholics Anonymous, for example. It's a 12-step program. It's where the patient can get support from their social resources, such as family, friends, or this AA group, and that's been proven to be pretty effective. Also, we have in our toolbox disulfiram, antabuse. So what this is it's a drug that causes a hangover effect to the alcoholic when they drink. Now, it requires that they take this disulfiram, this pill, every day, and when they drink then, they get these terrible, nasty side effects, such as hangover side effects, this GI problem, nausea. It's all due to the accumulation of a toxic side effect. So disulfiram doesn't always work because the patient has to take it every day, and most of them don't like those side effects, so they'll stop taking the disulfiram. So this isn't used for everybody. What we also need to be aware of in the treatment of alcoholism is that they are most likely thiamine deficient. So thiamine deficiency. We need to replace that vitamin B because instead of taking in a nice well-balanced diet, most alcoholics drink their calories instead of eat their calories. And alcohol does not have thiamine, so you need to replace the thiamine. Also replace the folate as well. And then lastly, one thing that we can do is, let's think back to our case example. The patient was in alcohol withdrawal, so they were experiencing some autonomic instability. What was the recommended course of action? It would be benzos, so benzodiazepines. Now we used a longer acting benzodiazepine in that example, so like diazepam or lorazepam, depending on the certain situation. So remember, you're going to start on a long-acting benzo at a higher dose, and as their symptoms gradually decrease, you're going to taper off of that benzodiazepine, because benzodiazepines can present kind of in the similar way that alcohol does. Alcohol withdrawal and benzodiazepine withdrawal are very similar. So you don't want to get them addicted to a benzodiazepine in replace of their alcohol addiction. So at the end of the day, start with a benzo, taper down eventually as needed. So those are kind of the basics of the treatment for alcoholism. Kind of depends on the certain situation that you're in, but this is the basics, and this is all you'll need for boards.